And we're broadcasting. Hello, hello, the world. Welcome to March's clinical webinar. Epicure hosts these monthly. We're so grateful for you joining us this evening. It is a gorgeous spring day here in New York. I hope you're all having lovely days as well. I know ours are about to get brighter with this wonderful presentation from Lauren Adler-Deer, who will be presenting case studies and nutrition interventions. We've been getting so many requests for case studies, so I hope, I'm sure, in fact, all of you are as pumped as I am to do some case study work. This is going to be a deep dive from last month's session presented by Marissa Sliver. Lauren is going to take us through treatment approaches for patients with eating disorders and digestive symptoms. So I am Jamie Hawk. I'm our VP of Network Development and Strategy, and I'm just going to take us through some housekeeping and introductions while everyone joins us this evening. So firstly, you'll be on mute for the duration of the webinar, but of course, Lauren will answer any questions you have at the end of the presentation. So at any time, you could submit those through your Zoom panel and the Q&A function. We will record the session, but we will not be providing slides. So certainly do take notes and look out for that recording that we'll send to you via email. We'll also be sending you your CPE certificate to all of you who are here attending live. So please keep an eye on your inboxes for that. All right, and with that housekeeping out of the way, I just want to give you a little bit of an introduction of Epicure for those of you who don't know. We work with just a phenomenal community of outcomes-driven clinicians like yourselves who are leveraging nutrition to help their patients get better outcomes. We're so grateful to be working with all of you, and you're alongside some of the best health systems, thought leaders, private practices, and patient advocates in the country and frankly in the world. It's been incredible to see a global audience come together like yourselves. So we partner with all of you, doctors and dietitians, to bring evidence-based nutrition to life as beautiful and delicious meals. Many of you are likely familiar with low FODMAP that has been shown to be efficacious for those with IBS, IBD, SIBO, and our food is also gluten-free, which works well for those who are celiac and non-celiac gluten sensitive. So it's really just Mediterranean, right, with a twist. We'll talk more about low FODMAP in other sessions, and we've got plenty of FODMAP 101 training in our monthly clinical webinars if you're looking for more information. So we take this 15 years of clinical research showing the efficacy of low FODMAP and turn it into pad thai and curry and lasagna and just wonderful things that people want to eat to feel better. And we know that low FODMAP can be really complicated and adherence can be very low. So we want to make your lives easy and your patients' lives easy by offering food for your patients to try. Even a few days of elimination phase friendly low FODMAP food can help provide you clinical direction before more in-depth education or invasive procedures, especially where we know that low FODMAP might be contraindicated in the cases that Lauren will be talking about tonight, where there's eating disorders or disordered eating. Low FODMAP isn't always the best first line therapy. Because all of our food is prepared and ready to eat, we take the stress of shopping and understanding low FODMAP out of the low FODMAP diet to just provide an enjoyable food experience that feels expansive instead of restrictive, and importantly, enables nutritional adequacy that can be missing on a low FODMAP diet. So we have wonderful plant-based meals, lots of salads and soups to ensure that they're eating the most expansive, vibrant, colorful plates that they can. We have lots of patient education materials that we invite you to use for your practices. And as partners in health, you get the best deal in town to offer for your patients. But really, why do we get up out of bed every morning excited to come to work at Epicure? It's for people like Helene here in Maryland who tells us they're a lifesaver, and they're grateful to their doctors and dietitians to let them know about this tool to make eating low FODMAP easy. And so with that, it's my pleasure to introduce you to tonight's presenter, Lauren Adler-Deer. She is a registered dietitian nutritionist with a private practice in Boston. She specializes in digestive health and eating disorders and has developed a keen interest in how the two overlap. She's an expert on the low FODMAP diet and treats a wide range of clients with digestive disorders, including IBS, SIBO, Crohn's disease, celiac disease, ulcerative colitis, and gastroparesis. Lauren is also trained in clinical hypnotherapy and offers this modality as an adjunct treatment to help manage digestive symptoms. As a reminder, submit your questions anytime in the Q&A panel below for our conversation at the end of the presentation. And with that, Lauren, I will let you take it from here.
Okay.
Thank you so much for your time. We're so grateful to have you.
Yeah, thanks for having me. I just need to take a minute to get set up. Okay. All
There
right.
we go. Perfect.
Okay, everyone can see it. All right. Thanks, Jamie, and I'm happy to be here. And as Jamie said, I'm Lauren. I'm a dietitian specializing in GI and eating disorders. And I'm excited for this talk. I'm going to do a little overview first and then get to the case studies. You may hear, just to warn you, I am pregnant and you may hear that I'm out of breath. So just keep that in mind when I'm talking. I'm also having some pregnancy back pain, so you may see me moving around, and just to give you a heads up. But my goal for this presentation is really to expand on the webinar from last month that Marissa Sliver did. And she presented on the same topic, the overlap of eating disorders and GI conditions. And she really did an excellent job presenting all the research related to these two conditions and why they overlap so frequently, how to assess our GI patients for eating disorders. So if you haven't already listened to it, and you want more background information on what I'm talking about, because I'll breeze over a couple things, I highly recommend you go back and listen. So. Okay, so I think this topic is so important because up to 98% of patients with eating disorders have a brain-gut axis disorder, such as irritable bowel syndrome, functional dyspepsia, and functional bloating. And these conditions used to be called functional GI disorders, but the new terminology is to use brain-gut axis disorders. That's what I will try to say. When we're looking at different types of eating disorders, you can see that over 90% of those with anorexia have digestive symptoms. About 70% of those with bulimia have IBS. And in one study, 93% of patients who met criteria for ARFID, avoidant restrictive food intake disorder, had fears related to digestive symptoms. These are just some of the common GI conditions in patients with eating disorders. And again, if you want to learn more about them, and you can go back to the other presentation from last month. So just going through gastroparesis, GERD or reflux, functional dyspepsia, bloating, IBS, functional constipation or diarrhea. So that would be constipation or diarrhea without abdominal pain, which is what is unique about IBS. Pelvic floor dysfunction, for those of you who don't know, is when the rectal muscles are really not working properly. And many of our eating disorder patients are more susceptible to this due to the overlap with anxiety. And also those with a history of sexual abuse are more likely to have pelvic floor dysfunction or dyssynergia. And what it does is create a lot of constipation and incomplete emptying. So it's a really important thing to assess for. And abdominophrenic dyssynergia is similar to pelvic floor dysfunction, but it pertains to the stomach muscles that are not working properly. And they're supposed to stretch after a meal, but in this condition, they're not stretching the right way. And so the abdomen sticks out and looks very bloated after eating. And you often see your patients bring you pictures, the selfie bloated pictures, which can be a sign of that condition. So when you're working with patients who have an eating disorder and GI issues, it's really important to assess and ask about eating disorder history. If you're a dietitian, I always think it's important to refer to a gastroenterologist. And I think it's important to note that eating disorder recovery is key. Some GI symptoms may resolve when the eating disorder behaviors resolve, but there's actually no evidence that all symptoms are going to resolve after eating disorder recovery. And so it's hard to know what GI symptoms will persist if the person continues to restrict or binge or purge, because the behaviors themselves cause GI issues. But even though recovery is at the forefront, it can be difficult if someone is in GI distress, how they're having so much pain and discomfort. So you need to be able to meet patients where they're at, and work on both the GI issues and the eating disorder at the same time, even though we do want to make the recovery and eating disorder behaviors primary. These are the nutrition treatment options I see available for these patients. And first off, I think it's good to know when to consult another dietitian or practitioner. And if you specialize in eating disorders, but you don't have a ton of GI experience, you can always have your patient consult with a GIRD, or even get consultation or supervision yourself, and vice versa. If you're a GIRD, you can always bring an eating disorder dietitian onto your team and work together. So, some things that, sometime I'm going to talk a lot about adequate meals and snacks, making sure that your patient is eating enough food. One option is having no dietary restrictions at all, and that may be necessary in some cases, absolutely. And we can recommend other things like supplements, and I'll talk a little bit about some of the supplements later. Won't go into a ton of detail, but also we want to assess for GI triggers, things like coffee, large meals, spicy foods, and alcohol. They may or may not bother our clients, and we may or may not take them out, but it's good to assess for it, as well as assessing for fluid and fiber intake. And I think with this population, a lot of times you want to make sure they're not having too much fiber, too much insoluble fiber specifically. But if it is appropriate to do a restriction, you can do, depending on the patient, you can do a lactose-free diet. You can do a modified GI gentle, and I'll talk about that later, but very, very modified FODMAP gentle diet. A textured modified diet, as the wonderful GIRD Tamara Dicker-Froyman coined, gentle diet, GI gentle diet. So making foods really soft and mushy so they're more easily digestible. And this can really help with gastroparesis and GERD and functional dyspepsia. And then increasing soluble fiber, that wet, mushy fiber, and really having people decrease insoluble fiber, the roughage and the bulky foods that take up a lot of room and can cause more distress. And here are some non-nutrition interventions, and I think these have been covered in some of the other previous EpiCured webinars. There's lots of medications that can help with GI concerns, so many different medications. Gut-directed hypnotherapy, behavioral therapy, and working with a GI psychologist if there is one in your area. We need more and more of them. So the problem is cyclical with so many GI issues. The symptoms cause anxiety, then the anxiety about the symptoms causes more symptoms. But for someone who has an eating disorder, it can be even more complicated. And for many people, it feels, with the GI issues, it feels better not to eat. If the food isn't going in the body, you're not going to have any symptoms. And this leads to more restriction, which leads to a more limited intake, and that can make the eating disorder behaviors worse, like more restriction, which can create binging and purging, and depending on what's going on with the patient. And then the cycle just keeps going around and around. So I just like to acknowledge this with my patients who have this overlap, because they know it so well, but having someone just say, like, I understand this is what's going on, can be really helpful. This information here is from an article written by 3 dietitians, Kate Scarlatta and Patsy Katzos, who are GI dietitians, and Janelle Smith, who's a GI and eating disorder dietitian. And they cite some research here showing in one study, 21% of functional or gut-brain access GI patients met criteria for ARFID. And then another study showing 12.6% of patients from University of Michigan were referred to behavioral health met ARFID criteria, but Even so, 71% of those patients were prescribed a low FODMAP diet, even though they were underweight or were having active weight loss. So they really, they clearly state that patients with GI issues need to be screened for maladaptive, or I'd say disordered eating, before an elimination diet is recommended. I know this is probably really small on your screen, but you can always look at the study um, and see what their criteria are. And I would say sometimes, even if an eating disorder isn't present, it's important to recognize, I think, especially in adolescents and young adults, that going on a restrictive diet can trigger an eating disorder. I have one client now who is in eating disorder recovery, and um, her eating disorder started when she was in high school after she was put on the low FODMAP diet, because it allowed her to be successful, quote unquote, successful in her eating disorder and restrict. And she had had some, of the risk factors and definitely disordered eating. But I think the prescription of a restricted diet kind of pushed her over the edge. It's just important that people are checking in, and that clinicians are considering all of this when they recommend the diet. This here is from the research team in Australia that discusses using a FODMAP gentle diet for certain populations. And they say not to use it for people who have an active eating disorder. And you can see why there's still quite a few foods here that it's still hard, even though it's not the full FODMAP elimination diet. It's still hard if you have to take out wheat and onion and lots of fruits and legumes, depending on what you eat. And so you'll see in the case studies that I do a very modified version of this, but I just wanted you to see it. These are the foods that are highest. I believe these are the foods that are highest in FODMAPs. And so if you're doing a modified version, you want to look at that list. So going to move into case studies now, just so you know, all the names have been changed to protect confidentiality. I'm going to start with Kara, who is a 26-year-old cisgender female. She was referred by her primary care for constipation, bloating, and distension. And she came in saying that her stomach looks 8 months pregnant. Can't remember if she had photos, but she really described as her stomach just totally sticking out. She reports an eating disorder history of binging and restricting. She had recently come off birth control and her period hadn't returned. She was currently eating gluten-free. She was doing her version of intermittent fasting, which was not eating after a certain time at night and then not eating till 1 p.m. She was definitely not eating enough. She was having no starch at lunch or dinner, and then she was having, I think, some fruit and some oatmeal for a snack in the afternoon. She is a very type A person, as she described herself, counts calories. She exercises up to 2 hours, 5 times a week. And she came in just wanting to know what foods trigger her IBS because she was so uncomfortable. She stated that she had tried Miralax, but it stopped working after 1 week. So at the first visit, I made 2 recommendations. One was to try the Miralax again, but go up to 2 capfuls and take it every evening. It usually works better so people can have a bowel movement in the morning, and to increase her intake. And we decided, we talked about it, and she was open to having some grains. So again, would I want her to have a lot of other things? Yes, but I wanted to meet her where she was at. So she said that she could add brown rice or quinoa to her lunch and dinner. So she came back at the second visit. She felt so much better with 2 caps of Miralax, and she said she was having multiple bowel movements a day. She also felt less distracted during the day because of adding more food to her lunch. And she did reveal at that time that she was currently binging and purging, which she hadn't revealed at the first visit. And, I think going along with her, she had these very specific goals, and she said, I want to know like what macros and how many calories I should be eating. And we had a discussion about how I don't make those recommendations. And I really wanted her to work on the the disordered eating and that I could help her with that. But I wasn't going to help her, with exact calories and macros. So for the fourth visit, she was having a really difficult time because she injured herself and she couldn't exercise. She did say that her GI symptoms were better, but they were still there. And at that visit, we were talking about other meals to have, and I made the recommendation for her to have a turkey burger with greens and avocado and quinoa. And her response was just, no one ever would ever eat that much for dinner. And I think through these sessions, and that comment in particular showed that she, was actually like that comment was really coming from her eating disorder, and that she was really not able to see that that is actually a very adequate, like it's not a large amount of food, too much for dinner. And I think because of the eating disorder and like being in that tunnel, not being able to see outside of it, she couldn't understand that. So I did make the recommendation that she reach out to an eating disorder treatment program, and she did do it. And she didn't actually end up coming back to work with me. I think the treatment center was, doing the intensive outpatient program was incredibly helpful for her. But I did get an email 6 months later that said she wanted to loop back now that she was further out of the program, saying that she really appreciated me referring and not pushing until she was ready. She said, I've worked most food groups back into my diet and have found that eating disorder behaviors and symptoms were the root cause of most of my GI issues. And this does not happen often, that it's so simple. Someone has GI issues, they go and get eating disorder treatment and then they feel great. I'm not saying that this always happens, but I think it can happen, and it's good to see this as an example. She's not saying all of her GI issues were gone, but she was having a lot of these GI issues because of the restriction and the binging and the purging. And so I think it's just an interesting example. So we're going to move on to Molly, who is a 25-year-old cisgender female. She was referred by her gastroenterologist. Her symptoms were having diarrhea up to 8 times a day, urgency, and fecal incontinence. Her eating disorder behaviors were restriction and binging. She did not come to me for her eating disorder. I don't think she had ever even been diagnosed with an eating disorder. But it was pretty clear, I like to ask a lot of questions and ask about disordered eating disorder behaviors, and she was pretty open and honest about it. She also had some trauma history of her mom really putting her on a lot of diets when she was growing up and withholding food from her. And so she was definitely having a hard time and was restricting and binging in those cycles. She wasn't restricting any specific foods for her GI symptoms, and her gastroenterologist recommended the low FODMAP diet from her. I don't think knew anything about the eating disorder. And so that's what she came to me for. It was not the first thing I did, because I thought it was more important to talk about what was going on with her relationship with food. I think a couple sessions in, I recommended a trial of a lactose-free diet because she was having so much diarrhea. And she did drink a fair amount of milk and have ice cream, a couple other like high lactose things. So we talked about just making some swaps, switching to lactose-free milk, lactose-free yogurt, and ice cream. And she came back the next time and she said she was having no accidents. Her urgency had greatly improved. She's still having diarrhea, but I mean, it's huge if someone's not making it to the bathroom in time. If you can improve that, it's great. So I think that was helpful. And in theory, she did want to try the low FODMAP diet because the GI recommended it, but she acknowledged that it was hard to restrict foods. And so we kept working together, and eventually, a few months in, came up with a very, very modified FODMAP gentle. So based on what she ate and and drank. This is what I recommended. I said, try cooking at home without onion and garlic, but don't worry about it if you're eating out. And she was drinking a lot of apple juice throughout the day, and we know apples are definitely high FODMAP, and even more high FODMAP if they're concentrated into a juice. So I was concerned that that was giving her diarrhea. So we talked, and she said she'd be willing to try lemonade instead. So we talked about trying lemonade instead, not cooking with onion garlic. And then she was eating some apples, fair amount of apples. And I said, well, just pay attention. Do you have worse symptoms when you eat apples or not? And so I was really taking out just a couple of things. And I also wanted her to notice how stress impacted her GI symptoms, because that's an important part of the picture. And so she came back and she said that I guess before I go on to that, I'll say that I think it was hard for her to notice a difference with the onion and garlic, cutting out the onion and garlic. And so I just had her start using it again. She did notice a difference with the apple juice. And so she did switch to lemonade. And the apples, I think, was dependent on what was going on. So this is another person that I did refer to eating disorder treatment. She started an intensive outpatient program. She did report symptom improvement with what she called normal eating, regular meals, and but the symptoms didn't all go away. And we had one conversation where she didn't make it to the bathroom in time, and the night before she had eaten onion rings, but she was also really stressed about moving. And so we just had a conversation. Well, it could have been the FODMAPs in the onions. It could have been the high FODMAPs and the higher fat meal could have triggered something, or it could have been the stress. It could have been a combination of all those things. It's hard to know. And let's just keep an eye on it for the future. So I worked with her for 10 months. She continued to follow a lactose-free diet, and she knew that if she made the decision to eat lactose, she knows what to expect. And so we know that someone can decide to have discomfort. It's not going to hurt their body, and she can make that decision sometimes. She switched to lemonade or other beverages instead of apple juice, and she's aware that some high FODMAP foods may trigger symptoms, but it's more likely when she's stressed. And at this point, she was moving away, so I transferred her to another dietitian, but she was still continuing to work on stress management and eating disorder recovery. I'm going to move here to Jim, who's a 67-year-old cisgender male. He was referred to me by another dietitian who doesn't specialize in GI. He came in saying that he had a PTSD history because 30 years ago, a diverticulum exploded in his intestines. He had emergency surgery, and part of his small intestine was removed. And so anytime he experiences GI pain, he had done a lot of therapy around this, but he still has a really hard time when he has GI discomfort because of that emergency. But he had GI symptoms over the years, but they started getting worse a year and a half ago. And he was having pain, discomfort, bloating, gas, and he had been losing weight. He went to a GI before he saw me, and he was treated with rifaximin. He didn't get tested for SIBO, but it was for presumed small intestinal bacterial overgrowth. And he was told to try the low FODMAP diet. And he came to me after he started it, and he said he was feeling 75 to 85% better. And his goals were to gain weight and to reintroduce FODMAPs. And he's not the typical ED GI patient, but the reason I included him is because I think he really would have met criteria for ARFID after going on the low FODMAP diet. And we continued, we worked together. We talked about adding more calories and how to add more food for weight gain. And we discussed the FODMAP reintroduction. He, would really say, like, it feels better not to eat, but, knows that he can't just not eat. And he did do some testing. Not of many foods. He was very afraid to test foods. I think once he went on the low FODMAP diet, he's like, I feel so much better. Why would I want to inflict pain. Like he felt like testing foods felt masochistic, and that he tested a couple things and had some stomach pain. And, he really just wanted to stay on the low FODMAP diet. And we had lots of discussions about why that wasn't a good idea to stay on it long term. And he had a hard time. He did gain weight, and I encouraged him to keep testing foods. And then he fell off my radar for a couple months, and then he came back a little over a year later, saying that he was still eating the same foods, that he was still following low FODMAP, but his symptoms came back. His diet hadn't changed. And so I think, this is when sometimes we need to realize that sometimes, like, this has nothing to do with food. And he wanted to know, should he take out more things? Should he take out chocolate? Should he take out this? Should he take out that? And I really made it clear, I don't want you to take out any more foods. That's not going to help the symptoms, because I don't think this is about diet. And so, like, we have to know that sometimes there's not much dietitians can do, and it's important to recognize that diet won't always solve everything. But so my recommendations were still to bring foods back in, to make an appointment with his GI. I thought it was interesting that he came to me before his GI, but I think he really needed to go to his GI to see if his bacterial overgrowth had returned, or if there were other medications or things that he could try. I thought that gut-directed hypnotherapy could be helpful for him. And at the time, I think for the pain and discomfort, I recommended he take enteric-coated peppermint oil before meals to see if that might help as a kind of anti-spasmodic. And I think with these patients, you see them and then you don't see them when they're feeling better, and then they might pop up again. So I'm not sure what happened. We don't always get the follow-up, but sometimes there's not much that we can do to help, and they really need to see their doctor to figure out what's going on. And taking away more foods isn't the answer. I'm going to move to Emily, who is a 26-year-old cisgender female. She was self-referred for her eating disorder and GI issues. She has constipation, bloating, gas, and pain. Her eating disorder behaviors when I started seeing her were really just restriction. She had had periods of binging in the past. She has been a lifelong vegetarian, and she came in avoiding so many foods. And I've definitely seen people that are only eating a few things, and I think this is kind of an overlap between like anorexia and ARFID. Now, technically, she's avoiding so many things, so it can't be ARFID because she has body image concerns. But there's definitely so many of these foods are GI fear foods because she's so afraid of getting symptoms. So she was avoiding all high FODMAP foods, high histamine foods, dairy, gluten, eggs. And remember, she doesn't eat meat either, or fish. And she was avoiding sugar and chocolate, and that was mostly because of the eating disorder. And, I've seen people with more, and I'm sure many of you have too, with even more restricted diets than this. I currently have a patient who, again, she definitely has an eating disorder, but it's very, very much also fear of foods causing symptoms. And she started taking foods out, and is currently only eating yogurt, has only been eating yogurt for 2.5 years. So, it can get so incredibly restrictive. My work with Emily has been adding foods and really working on variety and the constipation. When I first started seeing her, she was not having breakfast. She would sometimes have a morning snack. Lunch every day was a pancake made of rice flour, rice protein powder. That was the only protein she was eating, was rice protein, coconut oil, and kiwi. And for dinner, she was eating white rice or noodles with a bunch of vegetables, and she would make it all fresh every day, eat the same thing every day, and wouldn't eat any leftovers. So I first wanted to start with having her test foods that I thought that she would be successful with. So foods that were already low FODMAP that she wasn't eating. And we had, this is of course, I want her eating a wider range of foods, but we, had talked about what would she be willing to try. And, came up with this list of foods: tofu, pea protein, quinoa, spinach, some foods like that. And, I say to her all the time that when you have such a restricted diet, and I don't think there's research on this, but when I've just seen it, that any food may cause symptoms. Like anything new can just cause symptoms. And I think also, speaking of research, I just want to say there's not all of this information that I'm presenting. There's not really any research on what to do with these patients, and so this is just from my experience and what I do in the moment and my judgment. It's not always the right thing, but um, you know, there's no guidelines on what to do with our patients like this. So, but remembering, I think it's important for her to know, like, any food may cause symptoms. So I also asked her to drink coffee every morning to try to stimulate that gastrocolic reflex to be able to have a bowel movement. I had her increase her Miralax dose, and you really wanted her to be having breakfast, lunch, and dinner and snacks, be really eating an adequate amount of food. So I've worked with her for a year and a half, almost 2 years now. Treatment has been very, very slow, but she has made progress. She's eating many high histamine foods. She's eating, I didn't put it in here, but she is eating tofu. She eats tofu every day. She eats fish, and she eats leftovers now, a bunch of other fruits and vegetables that she wasn't eating before. It's still very limited, but is better. And one of her goals is to be able to eat out one time a week. She does that now, and even if she knows that it might bother her, she still does it. She eats breakfast. She's really is eating an adequate amount of food, and her GI symptoms have improved. Again, they haven't gone away, but they've improved. And we're still working on both her GI fear foods that she's afraid to eat because of GI symptoms, like beans, eggs, gluten, dairy, and her eating disorder fear foods are sugar and chocolate. So it's not always a fast process, but she is making progress. So this is Melissa. She is a 36-year-old cisgender female. She was referred for her self-referred for her GI symptoms, disordered eating. She has a history of bulimia. She was very committed to working on intuitive eating and had a therapist that specialized in the health at every size approach, and really did not want to restrict any foods. She does have a history of sexual assault, and her GI symptoms were nausea, bloating, constipation, and incomplete emptying. And so just right there, she's having that incomplete emptying, and she does have a history of eating disorder and sexual assault. I'm already thinking pelvic floor dysfunction. And she had tried Linzess, Amatiza, so medications for constipation that weren't helpful. Again, a sign that there's some pelvic floor dysfunction going on. She had tried a probiotic, and she had tried the low FODMAP diet with another dietitian in the past. My recommendations were for her to see another GI for a second opinion, to get an anorectal manometry test to diagnose any pelvic floor dyssynergia or dysfunction, and to try gut-directed hypnotherapy. And we discussed trying a GI gentle diet because I thought it may be helpful for some of her symptoms, but we really talked through it, and it was not the right time for her. She really didn't want to restrict foods, and it's important to have that conversation, and also know when someone says that they are willing to restrict foods when you think it may not be the right time. I did, because as Jamie said, I do hypnosis with my clients. I'm trained in clinical hypnosis. I know it's not necessarily common for dietitians, but I love to do it. I love to use it with my patients. So we did some hypnosis sessions, which are really helpful for her. But I think, we got into really working on her disordered eating, and that kind of fell by the wayside. Um, she did see another GI. Her gastric emptying test was normal. She was waiting for the anorectal manometry test. She tried a couple of medications, one being Cymbalta, but it had some side effects. And then she was on an anti-anxiety, something for anxiety depression, but she switched to Zoloft. And um, 5 months later, I worked with her for about 5 months. I think it. She was really full of stool. Her body was full of poop, and I think, like I had suspected with the pelvic floor dysfunction, she couldn't get all the poop out of her, and so because of that, she was having all this bloating and nausea. And so she went on the Zoloft, and the side effect of the Zoloft was diarrhea for her. And so she was having diarrhea 3 times a day. And she was like, I feel amazing. Like she was having minimal GI symptoms, no bloating, no nausea, and of course, no constipation. Now, I don't know if the side effects for her are going to be long lasting. And, I think diarrhea 3 times a day would eventually get old. So it's not the fix. I think, doing pelvic floor physical therapy is what she really needed. But, again, like it's not necessarily diet related. Like she was full of stool and it needed to get out of her body so she could feel better. So she was saying that she was wanting to eat more vegetables and more foods that were fibrous because she wasn't full of stool or FOS. And she scheduled pelvic floor physical therapy because she was feeling so well. Like we ended treatment for the time being. So just another interesting case. And I'm just looking at the time. I think what I'm going to do is skip. We can always come back to it if people don't have questions, but I want to make sure we have time for questions. So I am going to skip over my last case. If you're welcome to contact me if you have questions or you want to see some of the slides that I skipped over. But I want to talk about some other things before we do some questions. So I wanted to just talk about some specific tools you can use in your practice. This could obviously be a much longer presentation. So right here on this slide, I just wanted to focus on diarrhea and constipation. So, and I talked about some of these things in the case studies, but if you have a patient with diarrhea, then they may have IBS, but it's also important to have other conditions ruled out, like bile acid malabsorption, pancreatic insufficiency, other things that could cause diarrhea, that it's not, that they see a GI to roll out all these other things. And also soluble fiber supplements can be really helpful, using Citracel or Fibercon when someone's having a lot of diarrhea. If it is really IBS, there's medications that can help with IBSD and people are having diarrhea listed here. And then definitely the alternative therapies like hypnotherapy. If you have a patient with constipation, like I've said, you want to make sure that pelvic floor dysfunction has been ruled out. Are they having lots of other symptoms because they have pelvic floor dysfunction? You can also make recommendations for a bowel regimen, like using Miralax or magnesium. It may work, it may not. There's also a lot of medications out there that can work really well for constipation. And then, as I've said, are they getting enough calories? Because that's a big factor in constipation. Are they getting enough fluid? Are they getting too much of that insoluble fiber, that roughage type fiber? And that could just contribute to constipation and make it worse. So like I said, there's no research or guide that says when dietary restrictions are appropriate for this population. And this is kind of what I've come up with. But you can see that even in my case studies, even like I say, a GI diagnosis has been made. Well, even for someone that's waiting for the GI or hasn't seen someone, I will still do a very modified version of a FODMAP diet and have them experiment if it's appropriate. So, I think the patient needs to be eating enough. they're still having symptoms after trying medications or supplements. There's definitely people that don't really are against medications. But I try to I try to talk with them about how helpful they can be sometimes. I think it's helpful if someone is in therapy and can talk about this stuff with their therapist. And other techniques have, at least been discussed, that there are other things that they can do, like hypnotherapy, cognitive behavioral therapy, seeing a GI psychologist, and things like that. So in clinical practice, some dietary modifications may help their GI symptoms, and then that may help with eating disorder recovery, because if they're not feeling so bloated and so gassy, if they're not having diarrhea 6 times a day, or not making it to the bathroom, or they're not, if you can make some modifications, and if it's appropriate to make modifications, it really depends on how like deep they are in the eating disorder at that moment. But it can help recovery if the person feels better. And you really need to use your judgment and talk to the patient about all the options, including, which might be, eating disorder treatment. And any dietary restrictions should really be tailored to the patient. I think that's come across. And if it really triggers eating disorder behaviors, any dietary modifications should be discontinued. And then if the patient is already restricting foods, you want to decide together what to bring back in based on the restrictions. And then I like to start slow, start with one food at a time, and then go from there. And really talk about, are these restrictions helping your symptoms? Like, if you're already feeling gassy and bloated, and then we introduce a food and you still feel gassy and bloated, it's not necessarily making a difference. Like, you can eat a wider variety of foods and you may not feel worse. It's not always the food. And then also discussing the difference between bodily discomfort and harm. So like the person who can choose to eat lactose or eat beans when they have IBS, they may have discomfort versus physical harm to their body, like eating wheat if you have celiac disease, or eating gluten. So it's important to make that distinction. And tips to share with patients, really, as I said, trying any new foods may cause symptoms. If you're already on a restricted diet, cutting out more foods is not likely going to help the symptoms. Eating regularly in an adequate amount will help with recovery and digestive symptoms. And your body may be able to tolerate more foods at a higher weight. These are for people who need to gain weight. That's definitely not everyone with an eating disorder, but people at a more restored weight are often able to tolerate a wider variety of foods and not have them bother them so much, and not have as many GI symptoms. So I'll now move on to questions, but I first just wanted to thank some of my colleagues, Tamara Duger-Froyman, for teaching me most of what I know about GI nutrition. Thank you, Tamara. And my other colleagues, Stephanie, Kate, and Shira, for looking over and helping me review my presentation. And so hopefully we have some time for questions. I know I spoke fast. I was trying to get everything in, but we have 10 minutes, it looks like. Jamie?
Hi there. Sorry about that. Always tough getting off of mute. My fan's spinning on my laptop. Thank you so much, Lauren, for the amazing presentation. As a reminder, put your questions in the Q&A function at the bottom of the panel. All right, so our first question is about Molly. Did you recommend lactate pills when she wanted to consume dairy?
Good point. I did not. I could have, but I often find just going, I think lactate pills can work, but I find that just I think it works better for people to switch to a lactose-free milk or lactose-free ice cream and then use lactate pills, like if like those options aren't available. Because I want to know that, like I wanted to see if it would work. I don't think the lactate pills always do the trick. So it's
Hmm.
not going to it wouldn't give me the hard evidence that I wanted.
Hmm. Got it. And a couple other supplement type questions. Do you recommend Metamucil?
I don't usually recommend Metamucil, and that I mean, I think some people come in and they're on it, and it's helping them, and that's fine. I have them stay on it, but it is a combination of soluble and insoluble fiber. I usually go more towards um, recommending Citrusel um, or Fibercon. Um, I'm not against psyllium, but I I don't tend to have great results with it.
Great, thank you. And the next question is about Miralax dosage, and totally fine, I think, if you don't want to speak to the details, but the question was if 3 times a day Miralax that you referred to, is that one capful at a time? And are you aware of the upper limit per day for Miralax?
I don't know. I mean, if I'm ever recommending more than the bottle says, I have them check with their doctor. Um, because we can technically only recommend what's on the bottle. I think even with Miralax it says don't take for more than, a week or two. But no, it's taking all 3 capfuls at once. So 3 capfuls, not 3 times a day, but 3 capfuls all at once in the evening.
Got it. Okay. Um, okay. If a person has an eating disorder and they start eating more, can that cause the distress until they get used to eating more?
Absolutely. It always causes distress
Hmm.
until their body gets used to eating more. It is so uncomfortable for people who are in eating disorder recovery and who need to gain weight and eat more. And even for people who don't, who may be at a higher weight but they've really been restricting eating more, it can be really uncomfortable for them. And part
Hmm.
of it is just getting through that discomfort. And I don't think there's too much you can do about that. Um,
Yep.
yeah.
And can you explain more about pelvic floor dysfunction, and how sexual assault history might cause that? And the question, what is the anopelvic manometry test?
Okay, so the anorectal manometry test is basically, they also call it a balloon test. So what they do is they insert a little catheter into your butt with a little balloon, and the person has to push out the balloon, and they're testing like can they push it out, and how much time can they push it out, and they're testing the like different sensors um and like the rectal tone to basically see are their muscles, like pelvic floor rectal muscles, working properly. And so that's like basically simulating poop. Like so a lot of people like pelvic floor dyssynergia is basically like people who are you're trying to push the poop out, but it's not coming out. It's the muscles are going in the other direction. They're not working right. And
Mhm.
and I think like the I haven't looked at the actual studies in a while talking about the connection between pelvic floor dysfunction and sexual assault, but I believe it has to do, and also like anxiety, it has to do with people holding tension. And we hold tension in different places in our body, and so one place can be the rectum for a
Mhm.
lot of people. I had someone today who has vulvodynia, which is like a, I don't know how to explain it. It's like a, sensitivity, like a vaginal sensitivity. And she is now just starting pelvic floor physical therapy for her constipation. But she said to me, I know because of the vulvodynia, I hold so much tension down there. And
Mhm.
so part of physical therapy is teaching people how to relax those muscles, because a lot of time they're too tight. And so learning how to have the muscles work properly and have them not be so tight. So
Mhm. And a question about SIBO. Can SIBO be treated without antibiotics? Apparently, there was some information in a provider Facebook group, and that was a surprise. Is that something you can speak to, Lauren?
As far as I know, SIBO can definitely not be treated without antibiotics. I mean, as far as I know, there's no, I always tell people like diet cannot cure your SIBO. I mean, there was one study on using an elemental diet for 2 weeks that was, moderately successful for getting rid of SIBO. It's not ever something that I've recommended. Um, and I think SIBO is a hard diagnosis because it can, antibiotics, you have to figure out what the root cause is, because the antibiotics, they may help for a while, then it may come back because they have constipation or because something else is going on. So but as far as I know, the research says that's how it's treated, or I guess, antibiotics, but also figuring out the root cause.
Yep. Um, what would your approach with ARFID and autism and fear around GI distress be? Rachna points out she knows you touched on it a bit, but wondered if you had any additional thoughts on that.
I mean, I think I would need to know like more specifics about a specific
Yeah.
patient. Like,
Yep.
um, what's the question again? Working with ARFID and autism.
Yeah, and GI distress.
Yeah, I mean, I think it also depends on like where is the person on the autism spectrum. I think like, I mean, I don't. I think it's a hard question to answer without knowing like all the details about the situation.
Yep, totally fair.
Yeah.
Um, and Mary asked about for the patient avoiding leftovers. Why do you think she was avoiding those?
Because leftovers have a higher histamine content.
Hmm.
So especially, I mean, I believe, I don't know how much of a higher histamine content it is with like rice and vegetables, but certainly proteins. So like people who need to be on a low histamine diet because they have like mast cell disease or mastocytosis, they need to like cook food and then freeze it right away, because if they let it sit in the fridge, it will have a higher histamine content.
Hmm.
When people go online and look at all the little details and research everything, that's what they find.
Yep. Yep. Absolutely. Are your patients mostly recommended to you by GIs, or are they finding you directly? And I think that's a very interesting question, about how you've been able to grow your business like you have, Florence.
Um, I haven't tracked it lately. I think all over. Like I think I have a fair amount of doctors and GIs that refer to me. I think a lot of word of mouth. People who have seen me and then tell someone else. Um, and um, I actually get a lot of referrals from other dietitians. So I think
Mhm.
like I like to speak about this topic. And so people know I do GI and eating disorders because I've spoken about it at different places. And so I get a lot of referrals from, eating disorder dietitians or other dietitians that don't do GI. So, and therapists and eating disorder centers. And there's never a lack of patients, unfortunately.
Mhm. And
So,
as a follow-up to the histamine question, Julia asks how often you see patients who need low histamine diets and what are the indications that they might need that type of diet?
um, I don't see it a ton. I think Tamara, I think Tamara's listening actually.
She is,
She
yeah. She
sees,
gave
she
you a
sees,
thank you and shout out. Mhm.
she sees more histamine patients than I do. She's the expert there. But so if someone, some of the symptoms can be really similar to IBS, because having mast cell disease can cause diarrhea. But it can also, like, if you ask other questions, like, is the person getting flushing after eating or rashes? People are reporting these symptoms after eating very high histamine foods, like anything that's aged, like, or wine, cheeses, aged and fermented things, leftovers. Um, that's, but I like to be able, to get someone tested for this. And, here in Boston, we actually have a mast cell clinic. Um, But it can be hard because you might suspect that someone has some histamine intolerance and some mast cell, but it's hard, then to get them like to do some clinical testing to get their histamine and tryptase levels. And I think there's a like a 24-hour urine test that can be done. So, um, but for someone who has, it's basically for someone who has mast cell disease.
Right. And then our last question, Rachel asked about why kombucha is high FODMAP. I know that has to do with the fructans, but then she points to wondering about being able to leverage it as a probiotic and wondering about probiotic use to restore the microbiome.
Um, I don't use a lot of probiotics because I don't see them helping that often.
Hmm.
I'm definitely not against it. I mean, I think if you, and this also comes from tomorrow. I think if you suspect someone has SIBO, adding more bacteria to a bacteria problem is not always helpful.
Hmm.
But yeah, the kombucha. I mean, I always tell people it's like because they test it and it has high, like they put it in the machines and it tells us if it's high FODMAP, it's because of the structure of the carbohydrate and that's it. Um, but it doesn't mean that everyone with FODMAP sensitivities is sensitive to kombucha. So,
Hmm.
um, but I think that I don't tend to use probiotics because I don't always see it helpful. But if someone drinks kombucha and they think it's helpful, or eats yogurt and think it's helpful for their symptoms, then they should keep doing it.
Hmm.
Um, so
Wonderful. Thank you so much, Lauren. This was an amazing conversation. You got a ton of thanks in the Q&A and chat panels, and I'm sure everyone is delighted to hear that this recording will be available. Yep, getting more shout outs in the Q&A. So thank you so much for your time. Have
yeah,
a
thank you.
wonderful rest of your evening and go enjoy some lovely weather.
Yeah, and you can feel free to contact me. My email's up here if you have questions.
Very generous of you. Thank you so much. Have a wonderful evening, everyone. Bye bye.